Good day, everybody. Let me waiting for the principals to arrive. We had a cold spell in Miami. Well, not a really cold one, but for here it's cold. Hey, Sarah. Ibrahima.
Yeah, Mr. John, how are you?
Good. How you doing?
I'm good. How about you?
Okay, you got your camera there?
Oh, yes, I'm here. Give me a minute. Yes.
Okay, I sent an image for you to put in your background, if you don't mind.
Okay.
I
All
said
right.
it in the chat.
All right. Let me save it.
You're now on the payroll of Neurosurgical TV.
Of course.
We won't even put my face on. You're just going to say, hi, I'm Ibrahim, part of Neurosurgical TV team, and then introduce Ben.
All right. Choose a picture background.
Good day,
Hello.
Sanjeev.
Hello, how are you?
Good. How are you today?
Very well, thank you.
And Bonnie, England?
Yes, it's surprisingly sunny, but cold.
Oh, really? When you say cold, what do you mean?
Oh, I mean, not, I lived in Boston for 3 years, so not that cold, but
Okay. Yeah.
about 10 degrees
I
Celsius.
tell you, what the favorite place in the world I've been to is Westminster Abbey.
Oh, really?
I felt when I walked in there, I felt I arrived. I said, man, this is a center of civilization. When I saw the names Milton and all names go on and on and on, I said, wow, it was incredible.
It's an impressive place.
Yeah, it is. I mean, to someone who likes to read, it's like heaven.
Oh, you must go visit Oxford. You must.
Yeah, you are. Yeah. I definitely have to make a better tour. And I'd love to see the rest of England, a little bit of Scotland, maybe.
Yeah. Because you're based in Florida, is that right?
Yeah. You see, what I'm aiming for, Sanjeev, I may look stupid, but what I really want to do is travel the world and do webcasts and be able to support myself as I travel to say England for a month or Paris for a month. That would be in heaven.
Yeah.
So I'm aiming for that.
Yeah, good. I think it's fun. I mean, I love to travel as well. I think that's a great.
Yeah, to mix. Now you can. Well, on the internet, you can effectively travel with the right equipment.
Yes.
And it doesn't matter where you are.
Yes.
Actually, I think it would lend a little to the webcast if you did it from an area where you were at, and maybe get more involved. John.
Yeah. That's a good idea, actually.
Excuse me, because I got. Wanley, you can't get in. If you come in, okay, there you go. Okay. Yeah, Wanley. Ibrahim, are you having trouble getting it on?
Yes, but I can't even see the sign. I could not do it yet. I'm trying.
Hi, Wanley. You got your camera. I see it.
Yeah. I'm still in the cab back on my way back home, but yeah, I can see all of you.
That's fine. That's fine.
That's okay. Because Bing, she said he's out of the town, so maybe he cannot join us tonight, but that's okay.
Okay,
yeah,
so
I think he asked me to introduce Dr. Jerry Rana.
Sanjeeva.
Yeah.
Okay.
Hello.
Yeah. Sanjeeva. Yeah. Dr. Sanjeeva. Yeah.
Wanley's a cerebral vascular neurosurgeon from Chiatan Hospital in Beijing.
Oh, great.
So
Yeah.
he has credentials. He has very good credentials.
Sanjeeva. Yeah.
Nice to meet you.
And introducing Ibrahima. You couldn't get that on, Ibrahima. Could you get the
Yeah, I could
background?
not. No, I could not do it. I tried to log out and do it, but I could not.
Okay, I guess I'll just,
So I'm just going to grab some water. I'll be right back.
Ben's not coming.
Okay.
At the start. However.
Right.
Can you introduce Wan Lee? Do you know Wan Lee?
Wan Ling is which Wan Ling from
Wan Lee is
Tiantan?
cerebral vascular neurosurgeon from Tiantan Hospital in Beijing.
Mm-hmm. Okay.
Yeah, okay, you can introduce him.
All right.
What's the program? Is it just the one talk, or is there more than one talk? Or
It's the one, there's two talks. There's one by Zin Hu after your presentation. You're first.
Okay, I won't go too long. Probably maybe half an hour or something.
Okay. Well, whatever you feel, you know, however it goes.
Yeah.
Okay. Here we go. 10, 9, 8, 7, 6, 5, 4. Oh, hold on. I'm having trouble. Okay, here we go. Good morning from Miami Beach. It's Dr. John Bennett broadcasting for Neurosurgical TV. We have the pleasure of broadcasting our bi-monthly, the Chinese Neurosurgical Journal webcast. And today, I'm going to Ibrahim
Yes.
Suar
Yes.
is going to introduce the speakers. Welcome, Ibrahim.
Okay. Good morning, everyone. Good afternoon, everyone, to where you are in the time. And my name is Ibrahim Soare. I'm gonna introduce Professor Yuan Liao Chao. He's from Tiantan Hospital. He's a professor of cerebrovascular disease in Tiantan Hospital. He's gonna host this meeting to introduce Professor Sanjiva Jeratna. Professor Yan Liao Chao, are you here?
Hi, yeah. Thank you.
Go ahead.
So good evening from Beijing. Hi, hello everyone. Welcome to this bi-weekly webinar of Chinese Neurosurgical Journal. I'm from Beijing, and today we have two speakers. Please allow me to introduce the first speaker, Dr. Sanjiva. He's the skull-based surgery. We'll talk about the petrol surgery of petrous and the petroclivar meningioma. So please, Dr. Sanjiva.
Thank you very much. I'm just going to share my screen. It's a real pleasure to be here. I've caught some of your previous webinars, and it's very impressive, and doing a lot of good work. And Neurosurgical TV is doing a lot of great work. So thank you for the invitation. It's a real pleasure to be here for your China Neurosurgical Journal webcast. I'm the clinical leader or the director for skull-based surgery at Oxford, and also a member of IANA, which I'm very pleased to be in, and we're doing a lot of nice work there with webinars and various courses. Thank you for this topic. Petrous and petroclival meningiomas they're a challenging set of tumors to do, and one that we do quite a few of here in Oxford. These are the sort of cases we're talking about. The picture on the right is not a meningioma, but you can see the sort of difficult tumors that these are because of their location adjacent to the brainstem, the degree of brainstem compression, and the fact for a lot of these tumors, you have to work between cranial nerves. I put the picture on the right for the chordoma just because, we have a very varied case mix here. So we do lots of different things, paragangliomas, the meningiomas I'm going to talk about, chordomas, chondrosarcomas. And actually, we learn a lot from each of these, and we take the skills from one to the other. Today, I'm really going to talk about open approaches, not endoscopic approaches, because most of the meningiomas we're treating are quite tough tumors, and their lateral extension makes them really good for open approaches rather than endoscopic approaches. There's a big team involved in doing this here in Oxford, and I couldn't do these cases without the whole team. So when I show some of the pictures, videos, there's been input from lots of people, particularly the ENT, neuroanesthesia, and neuroradiology for these cases. But even for a center like ours that does a lot, we get complications. We can see facial palsies, things like that. and then ophthalmology and plastic surgery are heavily involved in those patients. So there's a huge team in managing those patients, and that's what gives us our results. I'm going to touch a little bit on radiotherapy. I know today's talk is really about surgery, but radiotherapy is important in these cases. Certainly, we've become slightly less aggressive in certain areas because of that, and we think that's a very good treatment. I'll talk about it briefly. I know this is a surgical talk, but just reminders as we go through all of this, there's a big team working with me. I touched upon what the team brings, but this is what we were able to deliver because of that large team. So we can go anywhere in the skull base. It doesn't matter whether it's orbit, infratemporal fossa, endoscopic, open, craniocervical junction. It doesn't matter, and we're able to reconstruct even very large defects without much difficulty. Again, because of what for example, here the plastic surgeons bring to the team. Also, we're able to discuss these cases in great detail in MDTs, which we have formally every other week, but on an informal basis, much more often than that. And we find that extremely helpful in deciding when to operate and how we operate. And as I touched upon earlier, when we have complications, we can manage all of them very well because of this large team. And it's a very comprehensive service because of that. And importantly, radiotherapy plays an important role in this, although today I'm going to talk almost exclusively about surgery, but I don't want to give the impression that's what we do for all our cases, and I'll touch upon that as we go along. So I think that's the most important thing to say here is that we get referred. We're a big center. There's a lot of hospitals feeding into us. Probably not as big as some of the Chinese centers, I'm sure, which I know are much, much larger, but still we cover a very large population. And so we have hundreds of tumors or more that we do not operate on. Okay, so there are small asymptomatic tumors. We watch them. They get serial imaging, start with yearly scans. And if they're stable, then we go to longer follow-up and usually follow these cases up for at least 10 years. So we have a large cohort that we do not operate on. The picture on the right is someone that we would operate on, and I'll talk about that. But there is a large cohort of patients. I just want to be very clear that not everybody's getting an operation. In fact, a lot of patients are not getting operations. So that's the first thing to say when we're talking about petrous and petroclival meningiomas. The second thing is I think radiotherapy is extremely useful in this group. And you'll see in some of the cases that I will leave, small residuals, particularly going towards Meckel's cave into the cavernous sinus. And we find the morbidity is significantly low from doing that. Once we remove the vast mass effect, we leave small residuals, and radiotherapy is highly effective for treating this. We have a Linac-based system, so we can go single fraction or fractionated. So that's what the FSRT thing is there on the slide. I put the slide here that this case that we actually operated on, but equally cases like this, they had significant comorbidities and things. We would certainly consider fractionated radiotherapy, and we can get patients through that. Admittedly, with mass effect like that, you get swelling and things which you have to manage with steroids. But fractionated or single fraction treatments are definitely an option in petrous and petroclival meningiomas, and that's important to remember. But really, most of this talk is now going to be on surgery. Okay, so what do we operate on? So it's usually large tumors like this. Almost always they're on growing tumors or symptomatic tumors. Almost exclusively, this is the sort of criteria that they are large, symptomatic, growing. Usually, to have symptoms from these large tumors, you're going to see significant mass effect, as you can see in these pictures. Particularly the axial MRI slices here, you can see there is significant mass effect on the brainstem. So you'd expect trigeminal symptoms. You can see the trigeminal nerve cutting right through the bottom picture there. So trigeminal symptoms, definitely balance, incoordination, maybe even mild motor symptoms, hearing loss, hopefully not to the point of getting swallowing difficulties, things like that. So that's really our criteria for what we would select for operations. But ultimately, it's patient choice. All patients are given the choice. Would they want surgery? Do they want radiotherapy? Do they want to be watched for smaller tumors? So patient choice does play into it, but we favor operating obviously on these ones that we've discussed. With these criteria on the slide here. The next thing to say about surgery is a really fantastic article from quite a few decades ago. And we're, as surgeons, we're really interested in approach selection. A lot of my talk today is going to be about approach selection. And of course, the maneuvers, arachnoidal dissection, some of the drilling nuances, and we're really, really keen on that. But I think, the more of these you do, particularly if you start to do some malignant work, you start to realize that tumor biology is king. And I put a picture here on the right of a petroclival meningioma that we operate on. This patient is actually a doctor. And this sort of petroclival meningioma where you have this peel involvement, and this cysts forming within the parenchyma of the brainstem, they're very, very challenging to do, we feel. And there is morbidity associated with it. And getting a complete resection can be difficult, and tumors can recur, even with radiotherapy. So I think we have to understand that tumor biology is king. How it interacts with the brain, how resistant it is to treatment, its growth rate, all of that. That is the most important factor. Now, there's no question in skull-based surgery, technical skill, approach selection, technical maneuvers make a big difference to outcomes. I think skull-based surgery, more than any part of neurosurgery, that really matters. And there's no question about that the technical skill and approach is hugely important. But I think we cannot forget tumor biology, and this petroclival meningioma of ours is one of them, and we have a number of cases. We have some malignant meningiomas that have metastasized despite very good surgical treatment and radiotherapy. I know today's topic is about meningiomas, but certain chordomas and things that are particularly aggressive can be very, very difficult. So I think we have to really remember that tumor biology is king. Yes, approach selection is hugely important. Yes, technical maneuvers are very important, but there is a hierarchy there. And Caddy, I thought, described this really beautifully in this article, Basic Principles in Surgical Oncology, and very relevant to skull-based surgery and this topic. Okay, having said that, let's get into the approaches we favor in the posterior fossa. So of course, there are endoscopic approaches, but today I'm going to talk about open approaches. All right. So I'm going to use Roton pictures because I love them. Really beautiful. I think I learn something every time I look at them. So this is a view of the posterior fossa from the back. Brainstem has been removed. We're looking at the basilar and the vertebrals and the cranial nerves. And the thing you have to remember is that the posterior fossa is wider at the top, and then it sort of cones in at the bottom. And how you get to it, well, there are a number of ways. So first is the anterior, or starting at the top, the anterior petrosectomy. So you obviously get fantastic access at the level of the trigeminal nerve. But for us, really, if the tumor is dipping a lot below the IAM, we find the Kawase less useful. Now, to be fair, if you drill extensively around the carotid, you can drop very low with the petrosectomy. If you really unlock the cavernous sinus and you skeletonize the carotid, you can drop much lower. Some people would go to the jugular foramen. We don't favor that. I think up to the level of the IAM, that's what we use. We were going for a petrous apex meningioma, and I'll show a case of that. The retrosigmoid is the king. I think that's the king for everybody. I'm sure a lot of you are using that a lot. I know a lot of high volume centers in China. And you must be using the retrosigmoid a lot, and we do too. So every week we will be using retrosigmoid multiple times for various cases. And we do a huge amount of our petrous meningiomas. In fact, it's a completely favored approach for petrous meningiomas. It's the standard retrosigmoid approach. There are extensions to the retrosigmoid approach, which I think, if you're a good skull-based center, skull-based surgeon, you need to be able to do. And I will talk about that. But retrosigmoid is the king and a true workhorse approach. And you can see you get a panoramic view from the tentorium all the way down to the jugular foramen. The other thing about the retrosigmoid, of course, because you're not drilling as much bone, you have to understand how you manage the cerebellum, draining CSF, all of those things. And we favor, not using retractors, so we won't use retractors really for anything. And that gives us a good feel of the cerebellum, that we're not injuring it, that we're draining CSF from it. So really outside today's topic, but the far lateral is an important approach to understand for foramen magnum meningiomas. So strictly speaking, not petrous or petroclival, but we would routinely, particularly if the CSF spaces were lower, we would open the foramen magnum in a sort of far lateral type approach to drain CSF, or we feel we needed a bigger exposure. So can we add it to the retrosigmoid, but strictly speaking for tumors at the level of the foramen magnum. And then you have, the slightly more complex approaches, the so-called transpetrous approaches. So these are retrolab additions, translab additions, transcochlear addition, or a combination of all of those with an anterior petrosectomy. And usually here you will cut the tentorium, and I'll show this. And we, I favor these for petroclivals. This is obviously not the only way to do petroclivals. You could do petroclivals clearly through a retrosigmoid approach, and then going supracerebellar and cutting the tentorium. That's also a very reasonable way to do it. But we favor these transpetrous, transtentorial approaches. You can see here that you get a great view, of course, of the level of the tentorium and above, but you are limited by the jugular bulb once you come in front of the sigmoid sinus. So you don't get that lower panoramic view you get with the retrosig. Obviously, you're coming much further forward, and we'll look at that. Okay, so these are, in general terms, the open approaches to consider for petrous and petroclival meningiomas. The other important bit of anatomy to really understand, we're going to look at the medial surface of the petrous bone in a minute, but just like, in the anterior fossa, you have to be able to understand both the endoscopic and open anatomy. Exactly the same here. You have to understand when you're coming medial along the petrous bone, what the anatomy is. When you're coming lateral in the petrous bone, what the anatomy is. You could talk about this slide forever, another beautiful Roton slide, but I'll just cover some of the main points. When you're looking at approaches and you're trying to decide, do I come retrosig, do I come on the lateral, you have to remember what each gives you. Most people will understand the retrosig, but what these lateral approaches give you, like this transpetrous, transtentorial, is the cutting of the tentorium here. That's what it allows you. By doing a middle fossa craniotomy and a pre-sigmoid craniotomy, you can cut the tentorium, retract the sigmoid sinus and superior sinus backwards. Venous understanding is important, particularly with things like the vein of Labe there and the superior petrosal veins draining upwards. So that's really important to understand. Obviously, you have to understand the petrous bone well, and the labyrinth and how that relates to the facial nerve, and the limitations of your view as you get blocked by the jugular bulb. We'll look at that in a bit later when we look at this transpetrous, transtentorial approach. Right, so let's start off with petrous meningiomas. As I said, the workhorse approach here is the retrosigmoid approach, and you have to really understand the retrosigmoid approach. You have to understand what going forward brings you. But for most people, if you're just doing a pure, simple retrosigmoid approach, we are talking about a craniotomy that goes to the transverse sigmoid junctions. As you know, the cerebellar surface then turns at an angle down here, and your craniotomy has to encompass that to allow you to drain CSF from cisterna magna and get in. So a very basic approach, but hugely helpful. And how that relates to the middle fossa and the pre-sig area is important to understand. And these are cases where understanding the retrosig and some of the pre-sigmoid drilling is important. The case on the right is one we did through just through a standard retrosigmoid approach and drilling of the IM, incredibly vascular tumor in a young patient in her 30s, very tight brain. We actually extended down a foramen magnum to drain CSF. And took out the lip of the foramen magnum off to drain CSF. And this was a case that essentially partly retrosig, but you have to understand how you go pre-sig and protect the facial nerve in a recurrent petrous meningioma. So we're going to kick off with just petrous meningiomas, operative petrous meningiomas. I'm going to talk about petroclival later, and the definition is really important. You'll see people, even sometimes in surgical series, confuse the two. Petroclivals are obviously much more challenging tumors, more morbidity, really, for most petrous meningiomas, although it's challenging, you really, in the large ones, particularly when they're deep, the morbidity should be low. really in a petrous meningioma. And the definition, of course, is the trigeminal nerve. So in petrous meningiomas, the origin is lateral to the trigeminal nerve, whereas in petroclivals, they are medial. So although this case has some lateral to the trigeminal, its vast bulk is medial. That's what this picture from the Neurosurgery Atlas is just showing there. The origin of the trigeminal nerve. But if your tumor is mostly medial in this case, or completely medial, then it's a petroclival. And there, of course, because of their depth, the deep blood supply, you're working more between the cranial nerves, much more challenging than petrous meningiomas, which are lateral to the trigeminal nerve. Really important distinction. I see a lot of people give talks, or they've given in papers, and the distinction is not clear. So that is a really important point to understand. One is much harder than the other. Okay. As I said earlier, not going to talk about foramen magnum meningiomas. They're done through far lateral. That's what this picture, operative picture on the right shows. You know, the meningiomas here. You've got brainstem and cerebellum. Nice tumors to do. Usually very nice arachnoidal planes. Far lateral gives you a beautiful view onto them. You get nice resections on them. But anyway, I'm not talking about that today. So let's get on to the petrous meningiomas. I've taken these pictures from this very nice paper from Mishiro Kuno's group, talking about the various extensions. Really good paper that I would recommend. And if you're a skull-based surgeon, you have to understand that. You have to understand, you know, what the standard retrosigmoid craniotomy gives you, and how to extend that in various places. Just like you have to understand the labyrinth and things laterally, obviously understanding the medial surface of the petrous bone is hugely important. Not just, you know, the basic things like the hypoglossal, jugular, and internal auditory meatus, but also you have to start to imagine where is the labyrinth going to be in relation to that. So, for example, you know, the labyrinthine block is there. Obviously, basic things like subarcuate fossa and the various tubercles that you may drill to give you further access. The next bit is understanding petroclival fissures and the venous anatomy related to that. So, you know, understanding, of course, superior petrosal sinus, the top where inferior petrosal sinus runs, and their drainage into the sigmoid and jugular. And these things all you'll encounter during the operation. The next thing to understand, and I've just drawn some lines here, is that you broadly divide petrous meningiomas into 3 groups. Okay. So, for example, this case here, which is quite challenging, the picture on the right is actually in the most anterior group. Its origin was here, just anterior to the internal acoustic meatus. And that's the most challenging of the group. So this first line here is just behind the trigeminal depression. Obviously, you start to go in front of the trigeminal nerve, that's petroclival. You have to start behind the trigeminal nerve, and this is a classification, I think it's from 1994. Stryker and Destroges, a French group, described it and very useful. So anterior ones are the most challenging, between the trigeminal depression and anterior lip of IAM. Then you've got essentially to the back of the labyrinthine block I talked about, group 2, and then from there to the sigmoid sinus, or sigmoid sulcus. And of course, the posterior group is the most straightforward, but also tend to be the largest because they have less symptoms initially. Certainly in a Western population, they are by far the largest, tend to present with massive hydrocephalus. As you can imagine, you get facial nerve symptoms, trigeminal symptoms, hearing loss, things like that in the more anterior group. These are the various bits shown. So the picture on the top is from the paper, picture on the bottom is one of our own operative pictures showing the retrolabyrinthine approach, which we quite like, and I'll talk about that. I think that's a nice extension to the retrosigmoid. But basically, as a skull-based surgeon, you have to be able to do all of these things, either laterally or inferiorly. So you should be able to combine your retrosig with suprameatal drilling, inframeatal, suprajugular. I'll talk about what is probably the most commonly used one, where you are drilling to open the internal auditory meatus. It's something that most skull-based surgeons who do retrosigs will be very used to, because we do it a lot for vestibular schwannomas. So we're really used to doing a retrosig and drilling out the porus acousticus. Of course, you can combine this with anything you like. We would commonly combine it with far lateral sometimes. But yeah, petrosectomies, transentorial, the options are endless. And of course, understanding that petrous anatomy is really important. This is just one of our operative pictures taken showing how a retrosig was combined with a retro lab approach to get further access forward and into the porus. Okay, just very quickly in the interest of time, obviously this is the retrosigmoid craniotomy. You have to be tight to the transverse and sigmoid sinuses, and two important points. As you must extend your craniotomy to take this bottom corner, really important. It gives you a nice view to a jugular femur when you do a retrosig. And take this bottom bit as the cerebellum turns down, gives you that nice access with no retraction to sternum magna, and that allows the whole operation to be done without retractors, just by a nice tight craniotomy, good positioning, and draining sternum magna. Right, so I'll just show a petrous meningioma here. So, you know, as I said at the beginning, I don't chase, this is the post-op view. You can see a bit of fat that's been placed just because of the retrolabyrinthine drilling. I don't chase meningiomas into the cavernous sinus. I will, of course, take chordomas, chondrosarcomas, trigeminal schwannomas, you know, soft tumors. We will take out of the cavernous sinus. We can do it very safely. Meningiomas, certainly for me, I don't do that. I know there are people who do it. I don't favor it. I think it's associated with too much morbidity. I think taking the vast majority of these tumors we've done here removes the mass effect and a lot of the symptoms, and it gives you the opportunity to treat that small residual with radiotherapy. And we find that very effective, very low morbidity. So you're going to watch a video in this case. It's a left-sided approach here. Okay, you got the mastoid exposed there because we're going to go a retro lab. Got the vertebral down there, although we don't need it, but it's exposed there. Just as you watch the video, just so you understand some of the anatomy that you need to get used to when you start adding things to the retrosig laterally. You have to understand, I think this is the case where we tied off the endolymphatic duct, understanding where the cochlear and jugular bulb is, and obviously the facial nerve when you're drilling. The other important thing here is to understand, you know, some people feel that just because you're not doing a translabyrinthine approach, you're not getting a good view of the IAM. That is wrong. Even with the retrolabyrinthine view in appropriate cases, you get a really nice view of the IAM. That's important because you're going to want to open the IAM. You have to open it either laterally or medially, usually to fish the tumor out. So really important to understand that even in a retrolabyrinthine approach, you get a really nice view into the IAM. You can get tumor out and get a nice resection. Okay. And that's what we did in this case here. I'm taking more time than I realized. So I'm going to skip forward. That's just the MRI scans for the tumor. You can see a small amount of tumor going in there, but we want that exposure there. We spent a lot of time planning on the CT scans, on the thickness of bone, where the jugular bulb is. You know, all of this, there's a lot of planning. We look at the sagittal views. So a lot of planning goes on to this to really, and this is a sort of view towards, and nowadays you can manipulate the software really well. So surgical planning is really, really good. I think in the interest of time, I'm going to skip forward. So I'm not showing the tumor removal here. I'm just showing the retro lab approach. So you'll remember you got external canal, facial nerve dipping down the labyrinthine block. We're coming behind it. Got a lot more to cover, so I'm going to skip forward. But I just want to show you that actually you can get the IAM. There you go. Taking the duct there. And as we go deeper, you get a really nice view towards the IAM. Yeah, so those are the gutters you're now drilling. You're drilling superior and inferior gutters around the IAM, just like you would in a trans-lab approach. Same thing in a retro lab. So really important to understand that you can get very similar access. You can really go into middle fossa as well if needed. Just to repair there, just see if we, just showing the final view there. IAM is exposed, you got superior and inferior gutters, and you drill down towards the jugular bulb. Okay, and that allows you to do this Nice views. Now I'll just show the opposite. So this is a different tumor now, and it's just to show that you have to be able to do this from both sides. So you should be able to drill the IAM from the lateral aspect, from the medial aspect. Okay, so now just standard retrosigmoid craniotomy, drain CSF, no retractors, arachnoidal dissection, arachnoidal peeling. Through this, low cranial nerves coming to view. Always working in that nice arachnoid plane. I think in the interest of time, I'm gonna skip forward. You'll see 7-8 coming to view there in the depths. Okay, so really nice planes and nice to work in the CB angle. Minimal, some bipolar, but minimal bipolar to keep your planes, keep your arachnoidal planes. And you just keep working them and debulking. The tumor comes away very nicely. Sometimes you have to use sharp dissection there. Sharp dissection, just take it all off. Usually the arachnoid peeling works. Good. Tumor coming away very nicely. See the brainstem in the depths. And then we start the drilling. Again, I think it's a slightly long video, but superior and inferior gutters. I'm just going to skip forward quite a bit in that drilling. Yeah, so then we've completed the superior and inferior gutter drilling. We've drilled out the IAM. We're now just taking tumor out from inside. Again, requiring some sharp dissection. And that's tumors out of the IAM, nerves all preserved. Just taking the superior bit out, that's trigeminal in the depths. So the patient is neurologically intact. Hearing is no worse. Facial nerve is preserved. And you can see a tiny residual there, but otherwise a very good resection. And importantly, the patient is very well. Okay, so standard microsurgery technique, retrosig, drilling out the IAM. I think in the interest of time, obviously the anterior preterist approach and understanding the anatomy of the carotid is really important. This is just a quick video. Actually, I'll skip this one. I'll show this small meningioma here. So obviously the key points here are doing an anterior preteristectomy is doing a good, very low middle fossa craniotomy and understanding the relationship of the carotid, the cochlea, and the IAM. And these are the key things to protect. This is a roton picture here where the trigeminal nerve has been cut and you've got the fourth nerve. These are the key things to protect here. Patient had trigeminal neuralgia, small tumor, we would have either watched this and given radiotherapy, but because of the symptoms, we decided to do an anterior preteristectomy and get a nice complete resection. Just showing the drilling here. We skeletonized the IAM enough to get this tumor out. You can go slightly further if you wanted. And obviously we protected the cochlea. Right, so first step obviously is always to split the cavernous sinus. This is V3, so you're taking the dura propria of the temporal lobe off the cavernous sinus, and then you're exposing the petrous apex. Really important to go forward, get to the trigeminal depression, because that's the true petrous apex to drill. Always start the drilling very medial. You want to drill medial and then drill back upwards. And you've worked out from your landmarks of the carotid, where carotid IAM and cochlea are. I don't think we've got time to talk about that anatomy in detail. So I'm going to skip forward. Right, then we've made cuts, both supratentorial and infratentorial, which is debulking the tumor and just finishing off cuts in the tentorium. Once we've picked up the fourth nerve anteriorly. So finish the debulking, nice view of the brainstem there. And of the medial vessels of the circle of Willis in a minute. Always working in the arachnoid, always. So we know patients are going to do very well. Just taking the last bits out there. There we go, the blood vessels there. Yep, and that's the sort of final view. Brainstem protected, vessels protected, last bit of tumor to come out anteriorly, just making the final cuts to remove the tumor. And that's the view at the end. Okay, nice resection there. Again, patients are neurologically intact. Just finally, this is an approach that we really favor. Really, we use it for petroclival meningiomas, but we have used it occasionally for smaller petrous meningiomas. This is the transpetros transenteral approach. And these are it is a complex skull-based approach. I do it jointly with the ENT team. There are, of course, neurosurgeons would do this solo. I quite like the team working. But essentially, you're doing a retrosig, pre-sig, and middle fossa craniotomy. The pre-sig can be retrolab, translab, transotic, and you must have an anterior petrosectomy. That allows you to then cut the tent, these lines shown here in this cadaveric dissection. And the top picture here just shows the meningioma. Black is the preoperative bone. Sorry, black is the postoperative bone. And you can see that the petrous apex and the retrolabyrinthine areas have been drilled out. We've preserved this patient's hearing and removed this tumor. That's the post-op scan there. Again, I don't chase it into the cavernous sinus, but it's just you can see the drilling involved. Hope you can see my pointer, the retrolab drilling, the anterior petrosectomy, and what view that gives you. We usually use this for petroclivals, and these are the indications that you could use it for if you wanted to. This is probably the most important bit. There are some really key points to this approach. Really getting and dropping the jugular bulb is important because that is a blind spot for us in this approach. That view is better retrosig. The retrosigmoid drilling is really important. It allows you to drain cisterna magna, but also importantly, really pull back the superior petrosal sinus and sigmoid sinus. If you want access to Meckel's cave, we do the petrosectomy. Of course, you cut the tentorium, and as in all the cases, it's an arachnoidal dissection. And these are some of the advantages, but really it's that working angle on either side of the trigeminal nerve. This is a chondrosarc we used it for. And like all of our cases, the venous anatomy and the bony drilling and planning is hugely important. We've really moved towards hearing preservation now for a lot of these cases, and we feel we can do that for them. Like I spoke about at the beginning, these are two very, very different cases. You can see a smooth plane here. It's not a meningiomas chondrosarc compared to a petroclival that's really PL involved in the brainstem. Patient on the left will come with problems, neurological problems, cranial nerve problems and symptoms, not so much the patient on the right. We think this is a predictor, so we do not expect someone with this sort of scan on the left to be better post-op. We do for the patient on the right. We feel we can make them better. The patient on the left, we do not. Our goal is to make sure they're not worse. So that's tumor biology again. Okay, so tumor biology really matters, and I think it predicts outcomes. A lot of these things, vascularity maybe, but the size doesn't matter as much as the other factors, the plane, the tumor consistency, and vascularity. You can take out large tumors if there's a nice plane and good consistency. But these other things do matter for petroclival meningiomas. These are the other approaches you could use, but we're going to focus on the transpetros transentoral today. Just a reminder again of what this gives you, not as panoramic, but I've extended this box here to say if you add your retrosig, then that does give you this lower down view. Just another example of the limitations, another cadaveric dissection. This view down here is not so good when you're pre-sig compared to retrosig. That's the sort of incision I use, a lateral position. Again, really important to understand that pre-sigmoid anatomy. If I then take that same picture and show you the retrofacial air cells that will drill, and then the drilling of the labyrinth. Obviously, if you drill the labyrinth, in the case I'll show you does that, you don't preserve hearing. Just a little cartoon to show you again that the cutting of the tentorium is a really important bit. It allows you to drag the superior petrosal sinus and sigmoid backwards, and that gives you a really good view going forward. And this is the view. You get a cartoon again. There's an intraoperative picture. This is the trigeminal nerve, the intraoperative picture, and you get this amazing view above the trigeminal nerve, which you just don't get on any of the other approaches. Really good views on both sides. Again, in a pre-sig view, going down here is harder. That you want retrosig. That 7-8 complex, that's 6. Okay, so I think in the interest of time, I'm going to skip forward on the drilling, but this is essentially the trans labyrinth drilling. Okay, you got superior gutter, inferior gutter, you've got your IAMs. That's the enteroepitheliectomy. We're trying a different scope. Now we're going to start our dural cuts. Okay. So the microscope view has changed slightly there because this is the descending facial. So we're just doing the cut. We've done the cuts in the middle fossa. We're now doing the pre-sigmoid cut, now coagulating across the zentorium. That's actually another really important point in this approach. I cheat a little bit by coagulating the tentorium down, but what you want to do is you want to cut a large bit of the tentorium out. Just cut a chunk of tentorium must be cut out. Just cutting through it's not enough. You must cut a chunk out. I cheat a bit by really coagulating it. And we're going to cut all the way down. Obviously, you're looking for the fourth nerve, which you will see late in this approach. Okay, so cutting down, cutting down, cutting down. There we go. We're going to just complete, sorry, the slightly blocked view there. Just completing the cut there. Okay, so now you can really retract superior petrosal sinus and sigmoid backwards. Fantastic view of 5. And you can see the huge corridors you get on either side of 5 that you don't normally get. As always, it's always a sort of arachnoidal dissection. You've got the tumor there, and we're just going to, that's the nice thing about walking around the brainstem. Usually you have these nice planes. You don't have it, it then becomes very, very difficult. But usually you have this nice planes. We're just working the tumor forward, working the tumor forward. Now we're going to start debulking it, getting out the box tumor. That's trigeminal nerve there. We're now taking inferior to trigeminal nerve. I think I'm taking quite a bit of time, so I'm going to skip forward. Trigeminal nerve here. So tumors coming out above, tumors coming out below. You can see this really nice corridor. And you get these angles working downwards, which are quite nice. Same thing, keep peeling, 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 and lifting tumor forward, lifting tumor forward, lifting tumor forward. I'll just get to the view of the end where you see the brainstem is nicely decompressed. There we go. Okay, lower cranial nerves. So brainstem is nicely decompressed. Still working, still some tumor there to remove. Now there we go. Nice view of the end. That's trigeminal. Tumor is out. Tumor is out. And you're just looking up towards the third nerve. Good. And you can take out some very, very large tumors with this approach. So quite a large tumor, but you can get nice resections. Again, we've left a small residual there going in, just because it was really stuck down in this case, and we didn't want to injure nerves going forward. But really good results. Just another example, this was a case that done in another center and came back to us 15 years later. Extensive tumor in the petrous bone, but just how you're understanding this anatomy, you can see all of this is going right towards the facial nerve, actually, and into the sinuses, all of which were resected. And hearing and his facial nerve are intact. Tumor comes out of the sinuses. We've skeletonized the facial nerve to remove the tumor. So just understanding that petrous bone anatomy, hugely important and really helpful. It allows you to take out a whole range of petrous tumors. Okay, I think I've taken up enough time. Just to conclude, these are very challenging tumors. We strongly favor the team approach. Lots of different strategies, including radiotherapy. As I've shown on purpose some of the cases where we've left some residual with very good long-term outcomes and low morbidity. But still, being able to take out challenging tumors on the brainstem is a hugely important part of managing petroclival meningiomas. Don't get me wrong, that operative skill and technique and these approaches are hugely important. And some things like this pre-sigmoid approaches useful part of the armamentarium for us. So thank you very much. It's been a real pleasure being here. It's just my contact details. If anybody wants to come to visit us, you're more than welcome. And thank you again for this invitation.
Okay, thank you, Sanjeeva. Excellent presentation. And now let's have a little discussion. Bimonthly, are you available to?
Yeah. Okay. Yes.
Go ahead.
Yeah. Yes, thank you, Dr. Sanjeeva, for your very nice talk. And actually, I think it's the first time I heard your parable about the king, queen, and the prince and princess. That's very interesting, and I think it's yeah. So also you show us a very a nice video about the different kind of those difficult surgery. Yeah, thank you again for your nice talk. Okay, so are there any questions from audience?
I'm sure there is. Just wait a second.
Okay.
Yes, I just have like one question for Professor Sanjeeva.
Go ahead.
That was a wonderful lecture and really decent and breakdown of all the petroclivar meningioma and the approach. And I would like, I don't know, in your experience, Professor Sanjeeva, do you often like put lumbar drainage during the approach? And what is the case did you put for it? Or all the case do you put only lumbar drainage for it? Any case of the petroclivar meningiomas?
I don't. So I'm not a big fan of putting a lumbar drain if there's a mass effect in the posterior fossa. Obviously, you can. People do it, and they do it safely, and they open it. Once the bone is off, and they're opening the dura. So it can be done. I don't like it, so I don't do it. So for me, it's all about trying to work out, how can I get CSF, bone, or tumor out early. So that's completely my approach rather than putting a lumbar drain. So for most retrosigs, getting cisterna magna or CSF around the lower cranial nerves and just relaxing the brain right down. Or if it's a very lateral tumor or get into quickly, you have the ultrasonic aspirator on a high setting and taking tumor volume quickly. Or it's drilling bone to get us onto the tumor directly and then getting the tumor volume. So those are the three strategies we use. So I don't think I've ever used a lumbar drain, and I'm not a big fan of it. But some people use it; they do it very well. So it's just
okay. Okay, and the other question is usually, how did you manage like the reparation of because sometimes the tumor is attached to the dura, you need to drill the bone almost to prevent the leak. What did you often do to prevent the leak after the surgery?
Oh, yes, that's a really good question. Yes, so and there can be a problem, but we've got a good system now. So actually, there's a few things. So one is if there's hydrocephalus, you must manage it. So no repair is going to stand up to hydrocephalus. Okay, so that's number one. We used to do a lot of things of trying to suture the dura very carefully, all this kind of stuff, and it doesn't, well, for us, sorry, it doesn't work. So we use fat. So fat works extremely well. So if we're doing a translab or any of these pre-sigmoid approaches, getting a proper dural closure is not possible. You can in a retrosig, of course, and that's fine. So we use fat, and actually we find our CSF leak rates it's not zero. We have had some through the petrous apex and things. So fat has taken our lateral leaks down to pretty much zero. The other thing we do is we put an endoscope in now, and I should have spoken about that, but we put an endoscope in at the end of our cases where we've drilled the petrous apex, particularly through a retrosig, because we've had one or two cases where we've missed air cells and have had to go back in to repair. So we find putting an endoscope in to make sure we've really sealed off the anterior petrous apex air cells, either with bone wax or fat or whatever is very helpful. And then, good closure, of course. You can get a pseudomeningocele, but it shouldn't come through the wound. That's really important. So all of those things. And there's a question on, yeah, thank you. I've just read a question about neuromonitoring. Sorry, I didn't speak about that. Yes, for petroclivals, we will routinely use neuromonitoring. If we want to preserve hearing, we will do brainstem auditory evoked potentials. Obviously, we're always monitoring 7 facial nerve, always, and usually monitoring the lower cranial nerves. But for petroclivals, we'll also monitor, a motor function, long tracks. So yeah, neuromonitoring, hugely helpful, really, really helpful to have in these cases, and very reassuring.
Okay, that's great. And any follow-up, like after the surgery, usually like the way you say you are not fan of lumbar drainage, for some kids, because you always do you put back the bone or do you replace by the plate? And after the surgery, do you often to control the ICP, do you use like any drugs or lumbar drainage later in case if the ICP is still higher or something like that? If the case you had like have a lot of bleeding, especially for this kind of meningioma who is very vasculated. So what is your protocol for
so
that kind of case?
So post-operatively, we don't have, it'd be very unusual for us to have post-op ICP issues. And that's because of, it's mainly arachnoidal dissection, keeping the veins and make sure the cerebellum is healthy at the end of the operation. So post-op ICP issues are very rare. So we don't always put the bone back because we've drilled the bone away. So in a retrosigmoid cranial, a standard retrosigmoid, we will put the bone back and we will put cement, bone cement sometimes to get a perfect seal. And that also helps with CSF leaks. So for standard retrosigmoid, definitely we put it all back and it's a perfect seal. And that's, of course, really important. All of them, you've handled the cerebellum very carefully. And you're not going to have postoperative swelling or anything, and you remove the tumor, and now the patient's going to be better. And that's all about arachnoidal dissection and protecting the veins. Hugely important. If you get cerebellar swelling, you've injured the cerebellum, essentially, or taken the veins or something like that. It can happen even in very good hands, with venous anatomy, but it shouldn't happen. In a pre-sigmoid approach, you can't put back the bone because we've drilled it, and there we put fat in a pre-sigmoid. So the retrosig and middle fossa craniotomies go back. Pre-sigmoid drilling, we put fat. And that is how we manage it.
And also I have another question from the Kawas approach by that side, because sometimes if you need to go down, mostly there's some vein who attached to the duro. Do you often coagulate it in your left side, by the left side, because usually most of the patients suffer like aphasia after the surgery? I don't know if you have any experience about that kind of situation or not.
So it depends which vein we're talking about. So obviously you must protect labbing. You cannot injure labbing. And in any approach there, you have to be very careful. If you're talking about the superior petrosal vein, then unfortunately, a lot of approaches where you cut the tentorium, you have to take it. There's no choice there. And if there's any concerns, of course, you could do a CT venogram, something preoperatively to plan it. But unfortunately, in transtentorial approaches, there is no choice in taking the superior petrosal vein. And again, in my experience, even when you've taken a vein that you didn't have a choice or whatever, and they're having problems, if you've handled the brain well overall in this long operation and you don't have a cortical injury, then, you can get patients through it. You want them set up, well oxygenated, well hydrated, physiologically optimized. And we're very lucky. There's a question here I see about ICU and things. All our patients go to high dependency. So they're physiologically optimized postoperatively. So, compared to some centers in the world, I'm sure, so you've got some very, very good centers in China that are also doing this. But we're very lucky in Oxford. So post-op care by the anesthetist is excellent for us. So they're awake, but physiologically optimized. So even if there are minor issues, we can get through it and recover patients. In vasospasm, we can drive their blood pressure. Things are picked up early. Complications are handled early and quickly and well. And that's because of the team I spoke about. It's not just me. It's everybody there. And so we're very lucky to have that.
Okay. One more
Wonderful.
question.
Thank you.
Okay, one more question before we move on to the next talk from Anthony Kabuva. What is the most common complication in your center, and do you manage post-op patients in the ICU?
Yeah, so they go to HDU, which is run by anesthetists. So they're awake, so they're not asleep. Most common complication, I don't know. At one point, it was CSF leaks, particularly this anterior apical CSF leaks, but we've taken that right down to 0 now by putting the endoscope in and using fat laterally. So probably that, I think. Yeah. And as I said in my talk, we've kept the morbidity low in certain areas, like the cavernous sinus. We don't chase meningiomas. We will take soft tumors out, chordomas, chondrosalx, schwannomas, but not these sort of tough meningiomas.
Okay, very good. Thanks a lot, Sanjeeva, for your time. And we're going to move on to the next speaker. Okay, Sanjeeva, thank you. One Lee, do you want to introduce the next speaker, please?
Okay, yeah. Thank you again, Dr. Sanjeeva. Now the second speaker will be Professor Xin Hu from West China Hospital, Sichuan University, and he will introduce their clinical trial Interact 3, which is a international multi-center clinical trial focused on the intracerebral hemorrhage. Actually, I think it should be the first clinical trial for surgical treatment of intracerebral hemorrhage with positive result compared with the conservative therapy, and their result has already been published on Lancet recently. So, Dr. Hu, please. Are you here, Dr. Hu?
Yes. Thank you. Thank you, Professor Zhao. And hello, everyone. And I'm honored here to be invited by Professor Zhao to share our latest result of the research, the Inter-3, which is intensive care bundle in acute cerebral hemorrhage. So I will introduce in the 4 aspects. So as we all know that intracerebral hemorrhage is a high disease burden throughout the world. The incidence of the intracerebral hemorrhages in low and middle income countries is significantly higher than that in the high income countries. Although with the past decades, the incidence of the cerebral hemorrhage decreased gradually, but the mortality still remains very high. And with the latest numerous efforts made in the last decades, also various large well-designed clinical trials have been performed, focusing both on the medical or surgical treatment, but there is no high-level evidence and for the effective treatment in the ICH. And the post-hoc analysis from the Inter-2 from our research team find that the combination of abnormal physiological parameters, including the hypertension, the hyperglycemia, the pyrexemia, as well as the warfarin use, is associated with the poor outcomes. So the aim of our research in Inter-3 is to determine the effectiveness of a care bundle protocol compared with the usual standard of care according to the latest recommendations from the guidelines. Our study, the Inter-3, is actually a stepwise cluster randomized control trials. We enrolled hospitals without ICH protocols. And we include only the adult ICH within 6 hours from the ictus. Also, the randomized, actually, I want to point out that this randomized is not focused on the single patient, but we randomize the hospitals. The primary outcome is the shift MRIs at 6 months and safety, the serious adverse effects. The secondary include the MRIs at other measurements and the knee score, death, and the quality of life. The sample size set is initially calculated as 8,360 patients. So with regard to the care bundle, it includes 4 aspects. Every aspect is actually goal-directed, has its specific target, and also include the early intensive blood pressure management, the intensive control of the blood glucose, and the pyrexia treatment, and the reversal of abnormal anticoagulation. We perform the intention to treat analysis and the sensitivity analysis as well as the subgroup analysis. Finally, after more than nearly 6 to 7 years hard work, we have screened more than 200 hospitals and more than 10,000 patients. Finally, 122 clusters were analyzed, and more than 7,000 patients were randomized. So, so the stepwise means we divided the hospitals into 3 sequences, and every hospitals will start as the standard care bundle, that is without the intensive care bundle. They just manage the patient with their routine work. And after that, at different steps, for example, in sequence 1, after period 1, the hospitals in this sequence will enter the intervention period. But in the sequence 2, they will enter the intervention group at the period 3. So this is different steps. And in the intervention group, we will train the hospitals to adhere to the intervention with the goal-directed intervention. So this is the characteristics of the patients included in our study. We can find that the NIS score or the hematoma volume is pretty various. And this in INTELLECT 3, the hematoma is larger than that in INTELLECT 1 or INTELLECT 2. And the blood pressure elevation is very common in patients. So for the total patients, we include 10 from 10 countries, and 9 is the low income and middle income countries, and 1 that is Chile in a high income country. For the patients, the Chinese account for most of the patients, more than 90%. And also in INTELLECT 3, this is also the biggest population for the surgery patients. Nearly 26% patients receive the surgical treatment. Also, Chinese is most active for surgery patients, for surgery treatment. In other countries, that is not that active. For the ICU admission, there is 11.6% patients transferred into the ICU. So we can find in these figures, the left is the hypertension control, and the upper is the blood glucose control, and the lower one is the temperature. Actually, this is more like a blood pressure control driven clinical trial. Since the blood pressure control is significantly different between these 2 groups, but at 24 hours, there is no significant difference in the blood glucose temperature control or the anticoagulant corrections. And for the outcomes, the primary outcome, we find that the care bundle can actually reduce the possibility of the poor 6-month functional outcomes. And this result or the conclusion remains even after the adjustment for several factors, including the countries, the pre-stroke MR score, age, or others. Still, that is significant different. For the secondary outcomes, the care bundle can reduce the patient's 6-month mortalities and also improve the patient's quality of life. Also, patient in this group has a lower rate of the serious adverse events. We also performed a subgroup analysis. The first subgroup analysis is focusing on the whole population. And in this subgroup analysis, we find that the patients in the African and Latin Americans were more likely to benefit from the care bundle. This does make sense, since in these countries, they have no protocols about the ICH management. But in China, since different, the blood pressure control has been advocated for several years, for many years. So actually, the sites or the included hospitals in China, they perform better than that in the African or Latin American countries. So the difference between the care bundle or the usual care groups is that not that large. Also, the care bundle may also be recommended for the higher needs score or large hematoma volume. This is new since in Intel 1 or Intel 2, they will only include patients with a small hematoma. But in our study, we include more large hematoma patients. For the second subgroup analysis, we mainly focus on patients from China. And this analysis showed that the patients with the higher needs score were more likely to benefit from the combination management. So in patients with acute ISH, the implementation of the care bundle include cooperation, intensive blood pressure lowering, the control of other physiological parameters in the glucose, the body temperature, and the reversal of the anticoagulation. Care bundle really helps patients. And the number need to treat is not that large. It's only 35 to improve the functional outcome or reduce the mortality. This is pretty important since there is approximately more than 3 million patients with ISH each year. But with this, the advocation of this care bundle, we can maybe rescue more than 100,000 patients from these treatment protocols. As also another important thing is that this study is an implementation study. That means we help the sites to perform better than before, especially for the African and Latin American hospitals. They have no very good or very formal protocols to manage these patients. But after this research, they have known how to manage, how to adhere with the latest recommendations from the guidelines. Since there is actually a gap between our clinical routine work and also between the routine work and the recommendations of the guidelines due to a lot of factors. For example, the skills, the economics, or their opinions. So I think this research will bring new hopes for the ISH management. And this is study has been published in Lancet in May of this year, and also we report our result in the ESOC. Thank you.
Thank you, Dr. Hu. Okay, thank you for your nice talk. And yeah, I think you gave us a nice introduction about your surgical result for the acute intracerebral hemorrhage. So are there any other question or comments from the audience?
Can I ask a question?
Go ahead.
Sure.
So have you seen a change of practice in China or in Asia following this trial? Do you have an idea about that? Or?
I'm sorry.
Have you seen a change in practice? Do you find that people are, based on this trial, adopting your findings, and do you find
yeah. Actually, after the training or after the research, the hospitals enrolled in our study, they perform a little bit better than before. But since, especially that in China, we have more mature protocols and they perform well, but not that good. And also we enrolled the hospitals, not the main territory hospitals, just in more rural hospitals. But the blood pressure control have been introduced many times in many years. So they have been worked a little bit better. So that is why we didn't actually in the subgroup analysis, although we find a significant difference for the whole population, but actually we did when focusing on the focusing on China only, we did not find that significant difference. We thought that is because they have performed good before. So the distance has been not that large.
It's interesting. Well, very well done. It's a lot of hard work, isn't it, running such a massive trial of that? So well done.
Thank you.
Yeah, I think I also agree that in China, I think many hospitals, the doctor, the neurosurgeon are kind of aggressive to do surgery for such kind of acute intracerebral hemorrhage. But after your clinical trial, I think now doctor pay more attention to the control of higher blood pressure, and also actually for the detail of the surgical skill, maybe we still need more and maybe another clinical trial to find which kind of surgical method better. For me, I think now I know more and more doctor like to use endoscope to do the hemorrhage evacuation.
Yes, exactly. And our next study or next publication will focus on the role of the surgery in ISH. And actually, the Rong Hu from Chongqing, they are conducting a multi-center trial with regard to the endoscopy surgery for the ISH patient. We're anticipating their result.
I think you have a big advantage in China, isn't it? Because the population you treat is so huge. Your results are very powerful from your trials because of the large numbers. It's a huge advantage you have. It's very good.
Yeah.
Well, we hope to exploit that advantage and use it for the good of neurosurgery, really. The numbers are amazing. So, okay, very good. Anything else to add before we close?
No, for me, yeah, no.
Yeah, thanks for hosting from the cab at the beginning. That was
Thank you.
very, very effective. And thanks, Sanjeeva, and thanks, Zenhu. And let me just quickly show you guys something that's coming up right now. There's a spine, the Pakistani spine board, which is a very active board on the internet, led by Salman Sharif. They're having a webinar in a few minutes, in about 45 minutes, if you want to check that out. Okay, very good. So we'll see everybody in 2 weeks.
Okay.